Inspection, there is fullness of hemithorax, diminished movement of that part of the hemithorax. Sternomastoid, the trachea may be shifted, that's why the sternomastoid sign may be positive on the opposite side. On palpation, the movement is diminished and the contralateral mediastinal shifting may be there. So, respiratory diseases are divided into 3 groups. In one group, the mediastinal will be shifted to the disease site, and that indicates either fibrosis or collapse or both. When the mediastinum shifted to the opposite side, it usually indicates pleural disease, and sometimes a large mass may compress the mediastinum towards the opposite side. And when mediastinum is central, it usually indicates bilateral disease like asthma, COPD, interstitial lung disease, or it may be in case of consolidation. In unilateral disease, in case of consolidation, there will not be any shift of mediastinum. So, shifting of mediastinum is very, very important. And on percussion, the percussion node will be resonant, hyperresonant, sometimes tympanic node may be there. And the spaces of dullness like cardiac or liver dullness will be obliterated. In left side pneumothorax, the cardiac dullness will be obliterated. In right side, the liver dullness will be obliterated or pushed downwards. Auscultation, breath sound, vocal resonance are usually decreased or absent. Now, chest radiology is important. The chest X-ray is the most important test and usually sufficient to diagnose pneumothorax. Usually, no other investigation is necessary. Chest X-ray finding includes ipsilateral hemithorax is lucent or absence of vascular marking, identification of collapsed lung border, mediastinal shifting to the opposite side, signs of primary disease. Suppose this is the chest X-ray and mediastinum will be shifted to the opposite side, heart will be shifted to the opposite side in left-sided pneumothorax, and there is increased lucency. That means there is some lung marking here in the same side, but here there will not be any lung marking and there will be a collapsed lung margin. This collapsed lung margin is very important for the diagnosis. So, lucency with collapsed lung margin, sometimes mediastinum will be shifted to the opposite side, and there may be the primary disease. You can see there will be a cavity or there will be emphysema, etc. CT scan. CT scan is advised in selective cases, particularly in secondary pneumothorax, to look at the underlying lung disease like COPD, cavity, tuberculosis, etc. In traumatic pneumothorax, sometimes CT scan is useful to look at the lung contusion. And CT scan is sometimes useful for diagnosis, differential diagnosis, pneumothorax from the cyst. Presentation. Presentation of primary spontaneous pneumothorax. So, there is no underlying lung disease. It is due to rupture of apical subpleural bleb. Now, what is bleb? Bleb is the small cystic spaces that lie within or immediately under visceral pleura, and they are normal findings and usually occur in adolescent, tall, thin-built boys. So, it is postulated that the thin ribs may, during respiratory movement, may be a cause of the rupture of the bleb due to sharp end of the rib may be the cause. Now, sudden onset of pleuritic chest pain. It is the pleuritic chest pain that occurs in suddenly. Means that patient can pinpoint the onset by time or event. Patient may say that at 9:30 a.m. I have the chest pain. Sometimes, but most usually, patient will give the history that I am coming from the school and while I was changing my dresses, I suddenly had the chest pain. And that is very important thing for the diagnosis of pneumothorax. So there will be chest pain followed by dyspnea, and sometimes the chest pain may preceded by a bout of cough. So bout of cough followed by dyspnea and chest pain, and this is very peculiar history of pneumothorax. Usually there is no past history of lung disease in primary spontaneous pneumothorax. In secondary spontaneous pneumothorax, what happens? The pneumothorax occurs secondary to underlying lung disease, usually COPD, TB, and any lung disease can cause pneumothorax. Any other lung disease, it may be interstitial lung disease or some other, may cause secondary pneumothorax. A patient aged more than 50 years who are smoker, a pneumothorax should be considered as secondary, not primary. Usually, patient has a long history of pulmonary disease like COPD, tuberculosis, dyspnea, etc. And how we can identify pneumothorax? There is sudden deterioration of the patient condition, or there is no improvement with treatment, the usual management. Then we should consider the possibility of pneumothorax. When patient is not responding or deteriorating with usual management of primary disease, secondary pneumothorax should be considered as a possibility. Now, what are the causes of secondary spontaneous pneumothorax? The common cause, it is COPD or pulmonary tuberculosis. Uncommon cause, cystic fibrosis, lung cancer, the pneumocystis jirovecii infection, and rare cause, some ILD like IPF, sarcoidosis, the pulmonary Langerhans cell histiocytosis, and lymphangiomyomatosis. The connective tissue disease may cause pneumothorax like rheumatoid arthritis, scleroderma, ankylosing spondylitis, Marfan syndrome, etc. Here some familiar condition may cause, like Ehlers-Danlos syndromes may cause pneumothorax. And one other peculiar thing is that catamenial pneumothorax, it occurs during menstrual cycle. In female, particularly in childbearing age group, two differential diagnoses should be considered. One is LAM, another is catamenial pneumothorax. Now, traumatic pneumothorax is the resultant of penetrating or non-penetrating blunt injury to the chest. Road traffic accident, history of injury, fall, or physical assault, blunt trauma, gunshot injury are important. That history should be taken. Patient may forget to tell it the cause as a cause of traumatic pneumothorax. Here, the pain is the most important thing due to refracture or something. And pain may be associated with collection of blood. Here, you can see there is a collection of blood here. And you can see the fracture of the rib. Here, you can see there is a fracture of the rib. Iatrogenic. We are going, now respiratory medicine becomes invasive. We are doing many invasive tests like needle aspiration, transthoracic fine needle aspiration cytology, or biopsy, central venous catheter, or invasive ventilation. They may cause iatrogenic pneumothorax. When a patient is in ventilation, the pneumothorax is very difficult to identify. It usually presents as tension pneumothorax. Sometimes it is very difficult to diagnose. A strong suspicion is very important. It should be suspected when patient condition is not improving or with adequate treatment. ABG parameter falls or deteriorated, a fall of oxygen saturation, and increased peak pressure and plateau pressure. Now, when a patient is under ventilation, patient is not improving with usual treatment, or patient is deteriorating despite usual treatment with fall of oxygen saturation. And in ventilatory parameter, if the peak pressure and the plateau pressure both increases, in those conditions, we should suspect tension pneumothorax. The careful examination of the chest X-ray is very important, otherwise you will miss the diagnosis. Why? Because in ICU, the X-ray are done in AP view. Patient is lying, so AP view X-ray is taken, and usually the quality of X-ray is not so good. So it is very difficult to diagnose pneumothorax by chest radiology. The deep sulcus sign is sometimes helpful in diagnosing pneumothorax. USG is very helpful. USG, it is a portable thing, and now it is found that USG is very helpful in the diagnosis of pneumothorax in a ventilated patient. I'll discuss it later. Now, there are clinical or pathological classification is there, but those classification is obliterated and now it is not mentioned in textbooks. They are open pneumothorax. Open pneumothorax means that the communication between